What if I told you that one decision you make in a doctor's office could completely reshape the final decades of your life? And it all started because you felt perfectly fine that morning. That you walked in for reassurance and walked out managing multiple procedures for conditions that might never have affected you? That's not a worst case scenario. That's a pattern happening in medical offices across this country right now, and it has a name. My name is Dr. William, and I specialize in how we make medical decisions for people after 65. For the last decade, I've watched the same scenario unfold over and over. Someone feels great, gets routine screening, and suddenly finds themselves dealing with medical situations that didn't exist before they said yes to that first test. The devastating part isn't that medicine failed them. It's that the system wasn't designed to ask the right questions before starting down that road. Today I'm going to show you exactly how this happens, why it happens differently after 65, and what you need to know before your next appointment so this doesn't become your story. Before we get into specific screenings, you need to understand something I call the longevity lens. At 50, the math of screening is clean. You find a problem early, you treat it, and you buy yourself more good years. That math works perfectly. At 65, it completely falls apart. Your body's ability to handle medical intervention changes dramatically. A surgery that bounces a 58-year-old back in 2 weeks could mean months of recovery, complications, lost independence, and a fundamentally different quality of life for a 73-year-old. That's just the beginning. Many conditions that screening finds in people over 65 grow so slowly that you will genuinely outlive them without ever knowing they exist. Except once they appear on a report, medicine doesn't have a leave it alone button. It has a treatment button, and that button almost always gets pressed. Then there's the cascade. One test finds something. That something triggers a follow-up test. The follow-up recommends a procedure. The procedure causes a complication. And a person who felt completely fine is now managing something that wouldn't have happened without that first test. Let's talk about prostate screening after 70. I'm not saying prostate cancer isn't real. I'm saying that for a man over 70 with no symptoms, the conversation most doctors are having isn't the full conversation. A PSA test can find a cancer growing so slowly that in a 70-year-old's life it would never spread, never cause a symptom, and statistically would never shorten his lifespan. He would live with it, not from it. But the moment that result comes back elevated, the system kicks in. Biopsies get ordered, specialists get called, treatment options get presented. For a man in his 70s, that treatment means radiation, hormone therapy, or surgery, each carrying serious risks to continence, sexual function, energy levels, and basic independence. The American Cancer Society changed their guidance on this because they realized the damage being done. They now explicitly recommend against routine PSA screening for men over 70 at average risk without symptoms. I had a patient named Raymond, 74, active, no family history, no symptoms. His routine PSA came back slightly elevated. Low-grade prostate cancer, the slowest moving kind. His urologist recommended radiation. 8 months after treatment, Raymond was dealing with chronic fatigue that grounded his mornings and urinary urgency that changed his entire day. He told me something I hear far too often. I felt better before they found it than I do now that they fixed it. That sentence captures what troubles me most. It's not rare, it's consistent. Every man over 70 should pause before agreeing to routine PSA testing. The question to ask isn't, should we screen? It's, what would we actually do if we found something? And is that treatment better for my life than carefully monitoring for symptoms? That single question changes everything. Now let's talk about bone density screening. Osteoporosis is real, and falls in older adults are dangerous. I'm not questioning that. What I'm questioning is the pipeline that immediately follows a low bone density result. Someone gets a DEXA scan showing below normal bone density. The doctor prescribes a bisphosphonate, drugs like Fosamax or Boniva. The message seems clear. Low bone density equals medication equals protection. Long-term bisphosphonate use, especially beyond 5 years, has been linked to atypical femoral fractures, stress fractures in the thigh bone, the exact bone you were trying to protect. These fractures can require surgery and cause more disability than the fall they were meant to prevent. There's also osteonecrosis of the jaw, bone deterioration that's painful and slow to heal, triggered by the medication meant to strengthen your skeleton. But here's what hardly anyone discusses. The single most effective intervention for reducing fractures in adults over 65 isn't medication. It's fall prevention. Studies on Tai Chi show it reduces fall risk by almost 50% with zero side effects. Balance training, removing trip hazards, installing grab bars, getting vision checked annually, reviewing medications for dizziness. These approaches reduce actual fracture risk more meaningfully than most pills. I had a patient named Gloria, 72, retired teacher. She got a DEXA scan, was immediately prescribed a bisphosphonate for the foreseeable future. 3 years later, she came to me with thigh pain that turned out to be an atypical stress fracture. She'd never fallen. She had no fracture history. She was taking medication to prevent a fracture, and that medication is what her bone reacted to. Before accepting automatic medication after bone density screening, ask, what is my actual fracture risk based on my complete health profile, not just the scan? Can we compare medication versus a structured fall prevention program? Any good doctor welcomes that question. Let's talk about cardiac stress testing. Your doctor says you're 68 and should get your heart checked. You get on a treadmill. They monitor your heart under stress. What could be wrong with that? Here's the problem nobody discusses. Cardiac stress tests in people without symptoms have false positive rates reaching 40%. Nearly half the time, the test flags an abnormality when your heart is actually fine. But medicine can't ignore an abnormal result. That false alarm sends you to cardiac catheterization, a thin tube threaded through blood vessels, through your wrist or groin, directly into your heart. Risks include bleeding, vessel damage, dangerous arrhythmias, and rarely, the catheterization itself triggers the heart event you were screened to prevent. If catheterization finds a partial blockage, which is extremely common in adults over 65, including many who live decades without a cardiac event, you'll likely get a stent. Listen carefully. Major clinical trials, including the ischemia trial, found that stenting in stable coronary artery disease didn't reduce heart attacks or extend life compared to medication and lifestyle management alone. It performed identically on outcomes that matter, but carried all the procedural risk and often years of mandatory blood thinners. The cascade looks like this. You feel fine, you get routine stress testing, the test falsely shows abnormality, you get catheterization, you get a stent, you go on blood thinners, you get ongoing monitoring, and your outcomes are no better than if you'd just taken medication and walked regularly. If you have no chest pain, no unexplained shortness of breath, no dizziness during activity, the conversation with your doctor shouldn't be about stress testing. It should be about optimizing actual risk factors: blood pressure, cholesterol, blood sugar, activity, sleep. That's where real cardiac gains happen after 65 with zero catheterization needed. Almost nobody discusses carotid artery screening, yet that silence represents one of the most consequential oversights in senior care. A carotid ultrasound looks at blood vessels in your neck carrying blood to your brain. The logic seems perfect. Find blockages before they cause strokes, surgically clean them out. The reality is far more dangerous. The surgical procedure, carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after surgery. In older adults with other health conditions, that number is higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery ultrasound in asymptomatic adults. Their reasoning is direct. In asymptomatic people, surgical risk outweighs likely benefit. A large portion of adults over 65 have some narrowing in their carotid arteries. That narrowing has often been there for years, stable, silent, causing no problems. When you screen for it, you find it. Then a well-meaning surgeon recommends fixing it. But surgery to clear a blockage that was never causing symptoms can dislodge plaque that travels to the brain. The intervention causes the exact outcome it was meant to prevent. If you have no neurological symptoms, no sudden vision changes, facial drooping, arm weakness, confusion, or slurred speech, routine carotid screening isn't recommended. Your energy should go to managing actual stroke drivers: blood pressure, which is the biggest one, blood sugar, atrial fibrillation if applicable, and staying consistently active. If you do have those symptoms, even briefly, get evaluated immediately. Finally, let's discuss colonoscopy after 75. Most people have never heard this challenged because colonoscopies have been so thoroughly endorsed that questioning them feels counterintuitive. But the data for adults over 75 with no symptoms, clean prior scopes, and no family history tells a different story. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening for average-risk adults over 75. The risks begin to outweigh rewards. Bowel perforation, a literal tear in the colon, occurs in approximately 1 in 500 colonoscopies. In younger adults, that's manageable. In a 77-year-old, it can mean emergency surgery, colostomy, extended hospitalization, and permanent changes to independence and quality of life. The bowel prep itself can cause dangerous dehydration in older adults, electrolyte imbalances, and cardiac stress. There's sedation risk, which climbs with age, and through the longevity lens, colon cancers most likely found in asymptomatic adults over 75 grow slowly enough that many would never cause problems within that person's remaining lifetime. I had a patient named Margaret, 78, retired teacher. 2 colonoscopies in her 50s and 60s, both clean. No family history, no symptoms. Her new doctor said she was due. Margaret asked questions, was reassured it was routine. The prep hit hard. By next morning, she was confused, weak, barely standing. Her daughter took her to the emergency room before the procedure. Electrolytes were critically low. Her heart was under strain from dehydration. She spent 5 days in the hospital and never had the colonoscopy. Margaret told me after discharge, I felt better when I was overdue for that test than I did after trying to take it. Instead of colonoscopy, ask about non-invasive stool-based testing like Cologuard or fecal immunochemical tests. These flag genuine warning signs without procedural risk. If you have symptoms, blood in stool, unexplained bowel changes, persistent abdominal pain, that changes everything. Those require evaluation regardless of age. Now, every time a doctor recommends screening, especially if you're over 65 and feeling well, have 5 questions ready. Write them down, put them in your phone, bring them to every appointment. Question 1. What is the false positive rate in people my age? This tells you how likely the test sends you down follow-up paths when nothing's wrong. Question 2. If this test finds something, what are realistic treatment options for someone my age and health status? Push beyond, we found something, to, then what? Question 3. What is the procedural risk of treatment we'd most likely pursue? Every procedure has risk, and you deserve knowing it beforehand. Question 4. What happens if we monitor this instead of treating immediately? For many conditions found in older adults, watchful waiting is legitimate and often superior. It's not giving up, it's doing math correctly. Question 5. What's the most effective non-invasive approach for this condition? Lifestyle and medication frequently outperform procedures with far less risk. Any physician genuinely in your corner welcomes those questions and won't make you feel difficult for asking. If a doctor dismisses these questions or makes you feel like a problem patient, that's important information about whether that doctor suits you. Here's what I want you to do starting today. Before your next appointment, whether next week or 3 months from now, write those 5 questions on a note card or in your phone notes right now. Bring that card to your appointment. You don't need all 5. You may need just 1. But having them changes how you show up, and how you show up changes what happens to your health. Try this for 30 days, 1 appointment, those 5 questions. By the end of 30 days, you'll feel like a different kind of patient, not difficult, protected. Someone who understands what tests are for, what follow-ups mean, and what questions to ask before cascades begin. Share this with someone in your life, a spouse, sibling, adult child managing parents' health, who needs to hear this before their next physical. You don't need to explain, just send the video. Subscribe to this channel. Next week, I'm covering medications routinely prescribed to adults over 65 that have completely different risk profiles at that age than at 50, and what to ask your pharmacist before refilling. If you're on more than 2 daily medications, that video was made for you. Leave a comment below. Have you ever had a routine test lead somewhere unexpected? Your experience might be exactly what someone needs to read before their next appointment. Take care of yourselves.